So the background is clear. We know that immune treatment and in practice it's about checkpoint inhibition, that it will improve the survival of patients with non-small cell lung cancer. That is the general idea, and we know that from metastatic disease that is also true. Now, we have seen the Pacific study, and that's a landmark study, where people with stage 3 non-small cell lung cancer, so-called locally advanced non-small cell lung cancer without distant metastasis, when they are treated with the current standard of care, that's to say concurrent chemoradiation, followed by Durvalumab as an anti-PD-L1 antibody, what we see is actually a clear gain in overall survival, which is sustained after even 5 years. And the absolute gain is in approximately 15% absolute percentages, and it's clear that is the best what we have ever seen in clinical trials the last even 20, 30 years or so. So that's a real improvement. And I should also stress that it's clear that those very good results can be reproduced in single institution or multiple institutional surveys, or I wouldn't call it studies, but more real live data. So I think that the improvement, what we see with Durvalumab as an adjuvant treatment is true. It's not just only in, let's say, an experimental situation. But of course, having said that, we also know that the majority of the patients will still have recurrent disease and will still die of their disease. So that's why at the time we started with the so-called Nikolas study. That was an ETOP initiative. And what we did is actually another checkpoint inhibitor, that's to say Nivolumab. It's also an anti-PD-1 antibody. We combined this with chemoradiation, but we gave it together with chemoradiation and followed by a year of Nivolumab. So instead of, like in the Pacific study, giving the anti-PD-L1 only after concurrent chemoradiation, we gave it also during chemoradiation. And the reason was actually that in preclinical studies, there's a good sign that indeed if you deliver this type of treatment together with chemoradiation, then it would lead to a better outcome, so better overall survival. And that was the backbone. Now, what we have seen in that phase 2 study is, first of all, it's safe. We see actually that although the CT scans look very scary, just like in Durvalumab patients, actually, that is, I think, a class effect when you combine checkpoint inhibition with radiation. That is that the CT scans look very scary, but on the other hand, the incidence of dyspnea, so shortness of breath, is actually very low in those patients, so comparable with patients without checkpoint inhibition. So the safety is very good, and there were promising overall survival signs. And therefore, it was decided we should go for a randomized study, of course, because this was not randomized. And the standard of care arm is actually concurrent chemoradiation followed by Durvalumab, so call it a Pacific regimen. And the experimental arm is then Nivolumab concurrent with chemoradiation followed by 1 year of Nivolumab. So that is also what we think is possibly better based on the published Nikolas study. But then there's a third arm, that is, can we even improve that second arm? And that is by adding to Nivolumab concurrently with chemoradiation followed by 1 year of Nivolumab. Can we add, by addition of Ipilimumab, can we further improve the prognosis? And that is, of course, because Ipilimumab works through another pathway. That is, it doesn't block the PD-L1 pathway, but it blocks the CTLA-4 pathway. And this is complementary. And in stage 4 disease, there are indeed data showing that the combination would lead to a better overall survival. There, of course, the toxicity of Ipilimumab may be a concern, like we have just published actually also in another ETOP study called Stimuli. It's just published in Annals of Oncology, where we have shown that in small cell disease, indeed, the tolerance can be a problem. But on the other hand, of course, this was another patient population that was small cell. Now we are talking about non-small cell, and those patients have other characteristics. So basically, there's a lot of rationale to combine Nivolumab together with concurrent chemoradiation based on the Nikolas study, and also to add Ipilimumab after concurrent chemoradiation and Nivolumab because of the beneficial effect in stage 4 disease. And we know that the majority of the patients still die because of distant metastasis. So that's the backbone. And I should say that all 3 arms of this study, there are very good toxicity data, like I mentioned to you. So from the point of safety, I think it's a very sound study. Actually, it's also true that not only for improving overall survival and PFS, of course, but on the other hand, there's also a lot of translational research in there in that study based on the tissue, based on the blood, and not mandatory, but possible also in the feces, so the microbiome, which all can have an influence on the immune response of patients. So it's a broad spectrum what we are looking at, and it's also a global study. With a lot of quality insurance, because in the Pacific study, and it was a landmark study, so no question about that, but we don't have detailed data about the quality of the radiation delivery and so on, whereas in the CheckMate 73 L study, we request to all participating centers that they upload their radiation plans before starting the treatment even. So in order to make sure about the delivered quality of radiation and of the systemic treatment as well. So and the study is running quite smoothly. So that is actually what I wanted to say about the CheckMate 73L. But of course, I cannot show any results yet because the study is ongoing.